Welcome to Pulse Pressors, where critical care gets crystal clear. VATS is a minimally invasive thoracic surgery technique using a camera and small instruments inserted through the chest wall. Many centers now use uniportal VATS, which accesses the chest through a single intercostal space. Uniportal VATS reduces pain, improves cosmesis, preserves chest wall mechanics, and allows advanced resections like lobectomy and segmentectomy. Candidates for VATS include early-stage lung cancer, requiring wedge resection, segmentectomy, or lobectomy; recurrent pneumothorax, requiring bolectomy or pleurectomy; empyema, requiring decortication, pleural biopsy, and mediastinal mass removal. These surgeries carry less morbidity than thoracotomy and allow faster return of pulmonary function. Intraoperatively, one lung ventilation, OLV, alters physiology significantly. The non-ventilated lung collapses, creating shunt physiology. Hypoxic pulmonary vasoconstriction helps redirect flow, but is imperfect. RV afterload increases, and permissive hypercapnia is often tolerated to protect the ventilated lung. Reperfusion injury occurs when the collapsed lung is re-expanded after prolonged one-lung ventilation, triggering a sudden inflammatory capillary leak. This produces post-reexpansion pulmonary edema, especially in higher-risk settings like pneumonectomy. High FiO2 during OLV amplifies oxidant stress and increases the likelihood of endothelial damage, making cautious oxygen titration essential. Intraoperatively, a double lumen tube enables full collapse of the operative lung for exposure, supported by digital bronchial suctioning to remove secretions and prevent partial inflation. CO2 insufflation is rarely used because it raises intrathoracic pressure and can impair venous return. Throughout the case, hemodynamics must be carefully controlled. OLV increases RV afterload and reduces preload, making anesthesiology surgery coordination critical to avoid hypoxia, hypotension, and arrhythmias. Postoperatively, priorities shift to lung re-expansion, pain control, and early complication detection. Adequate expansion prevents atelectasis and VQ mismatch, while multimodal analgesia, such as ESP blocks, paravertebral blocks, or cryoablation, allows effective breathing without splinting. Chest tubes must be checked for proper suction, oscillation, and drainage, as abnormalities may signal obstruction or tension physiology. Air leak evaluation begins immediately after surgery, guiding management if a prolonged leak develops. Early mobilization, incentive spirometry, and chest physiotherapy are essential to restore ventilation and prevent pneumonia. Pain control is paramount. ESP blocks are now widely favored for their safety and effectiveness, offering comparable analgesia to paravertebral blocks with less risk of vascular or neuraxial puncture. Paravertebral blocks remain excellent for deep thoracic anesthesia. Epidurals are reserved for thoracotomy-level pain. Cryoablation reduces narcotic requirements significantly. Chest tubes are placed to drain air and fluid. Digital drainage systems allow precise measurement of air leaks. Autotransfusion units may be attached for lobectomy or decortication cases with expected bleeding. High-output drainage requires surgical evaluation. Dependent fluid obstruction must always be considered. Prolonged air leak, PAL, is the most common complication after VATS. A top-tier ICU uses a structured algorithm. Maximize lung expansion with suction early. Transition to water seal on days 4 to 5. Use talc slurry or doxycycline pleurodesis when the lung is fully expanded but leaking persists. And consider endobronchial valves or surgical repair if leaks continue beyond 1 week or if there is ongoing pneumothorax. Chest tube red flags point to urgent complications. No oscillation means blockage. Rising subcutaneous emphysema suggests a major air leak or malposition. Sudden hypotension and tachycardia may indicate bleeding or tension physiology. Drainage over 200 milliliters per hour signals possible hemorrhage and requires immediate action. Postoperative arrhythmias are common, especially atrial fibrillation between postoperative days 2 and 4. Right-sided lobectomy carries the highest risk due to atrial manipulation. Prophylactic beta blockers, or amiodarone, are recommended in high-risk patients, along with strict electrolyte optimization. Magnesium greater than 2.0, potassium greater than 4.0. AFib after lobectomy significantly increases morbidity and length of stay. Pulmonary hygiene is essential, including incentive spirometry, early ambulation, bronchodilators, and chest physiotherapy. Atelectasis is the leading cause of postoperative hypoxia, not pneumothorax. Chest tube removal requires stable imaging, minimal drainage, and no air leak. Removing too early risks tension physiology. Too late restricts mobility and increases pulmonary complications. Escalation is needed for worsening subcutaneous emphysema, persistent hypoxia, high-risk arrhythmias, suspected reperfusion injury, tension pneumothorax, or high chest tube output. PPE presents as sudden contralateral hypoxia after reexpansion and requires aggressive supportive care. VATS is deceptively minimally invasive, but physiologically powerful. The best ICU clinicians manage these patients through a deep understanding of lung mechanics, chest tube physics, arrhythmia risk, and early recognition of air leak complications. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.